Good evening, everyone, and welcome to episode 12 of the Pain Consultants USA podcast. Tonight, Dr. Bonner and I are going to be talking about sacroiliac joint pain. This is a pretty interesting topic, if you ask me. This plagues quite a few people. It's somewhat controversial, and there's quite a few things that we as physicians can help instruct patients to do on their own to figure out if your pain is coming from there, as well as some self-treatment. So hopefully we can get into all of that and more tonight. But first, Dr. Bonner, if you can kind of just lead off the conversation by kind of reviewing with us, well, what is the sacroiliac joint? Where is it? What's its function? And so on.
Yeah, good evening. Good to talk to you again, as always. So I got my trusty model here for those that are listening on the podcast. We will be putting this video on YouTube, but I have a spine model, and looking at the spine from the backside, the lower part here is called the sacrum. And then if the model were more complete, this sacrum would connect to the pelvis, and that would be where the sacroiliac joint occurs, which is right here on either side of the sacrum there. So sacroiliac, the ilium is the other part that comes into the joint. If we look at it from the side, it's kind of like a C-shaped joint. So it goes this way right here. And it's got kind of a rough edge on each side. So it's not, it's not maybe as smooth as some of the other joints that we commonly think of, like a hip or a knee or a shoulder joint. But that's part of the importance of it, is it creates a lot of stability in transferring loads from the spine down through the pelvis, or kind of up the other way, loads that are coming up from the lower extremity through the pelvis and then into the spine can be transferred through that joint. And so it's a pretty important joint, as you were saying. I think we can see a reasonable amount of patients who have pain coming from the joint, and maybe it's sometimes a little bit harder to identify. I think there's a lot of different numbers out there for how many patients with low back pain are really having sacroiliac joint pain, but it may be somewhere, I don't know, 10 to 30% or something, and it depends on the different populations. So it's definitely something that we're looking for as practitioners, and it's definitely an important cause of low back pain for us to identify. And I don't know, what do you think of when you're looking to identify it?
Yeah, I think, like you said, it's an important structure. It connects the low back or the lumbar spine to the pelvis. And the pelvis is obviously connected to the hips and the lower extremities. So it's pretty vulnerable to, peripheral joint issues like hip osteoarthritis or knee arthritis that causes you to walk funny, or, limp. You can kind of aggravate that joint. The one other thing on that model, if you could pull that back up,
Yeah.
and just show kind of the backside of the joint in an AP view. There's also a bunch of ligaments on the backside of the sacroiliac joint that, if you hold up like your hand as if it's the iliac or the ilium there. Yeah, right. So in between where Dr. Bonner's hand and the joint, where that forms, there's a whole complex of ligaments that actually run over top of that joint as well. And we're learning more that some of those ligaments themselves can be the cause of pain. And that's actually even separate than the joint itself. So
Right.
you can have sacroiliac joint pathology or issues, as well as the dorsal ligament complex. And treatments are a little different. Treatments for the ligaments, they're evolving. So that's also something that hopefully we can touch on tonight.
Yeah.
But to get back to your question, with sacroiliac joint pain, there's certain populations that are more vulnerable to issues like that. In older populations where we commonly think of the wear and tear arthritis type pain, that could be a portion of patients who have really low back, kind of buttock discomfort. Individuals who are pregnant, right, during pregnancy, hormone levels affect kind of the laxity in the ligaments and certain joints that really depend on ligaments for stability can be affected, and sacroiliac joint is one of them. As well as, after giving natural birth, you think about the child through the pelvis and the pelvic ring, that a lot of things can be kind of get out of place. Other individuals would be different in like autoimmune conditions, where there's a whole group called seronegative spondyloarthropathy, which is a fancy term, but people who might have psoriatic arthritis, Crohn's disease, or other like ulcerative colitis with joint issues as well. Those are conditions where this might be a little more common. You might even see some commercials for something called ankylosing spondylitis. There's some medications that are currently being advertised for that. Those are people who this might be more common in. And then some trauma, right? Any kind of stress through the pelvis itself can predispose you to that. So those are the type of patients I often think about sacroiliac joint pain in. Do you want to review, I guess, what a typical presentation of pain may be, the location, and where it may travel?
I would just add to that, right, previous surgery. Did you say that? I might have missed that. But
No,
if you
no,
had
that's a
if
big
you
one.
had a surgery on your spine, if you had a fusion surgery at the lowest levels, I'll take this model out again one more time, but if you've had a fusion surgery of the L5 and S1 levels, what naturally happens is you get more stress placed on the sacroiliac joint because it's the next kind of level down from there, because all the sacrum is all fused levels. So there's no movement between the different bones in the sacrum. So all that movement from that joint gets moved to, most of it gets moved to the level above and the level below, and the level below is the sacroiliac joint. And so that's a place that we think of in people who've had a fusion surgery and developed new kind of back pain. And then we can talk about kind of where that back pain is. So it's often most typically one-sided. Now, if you have problems on both sides with both sacroiliac joints, it could be bilateral, which we do see sometimes. But if you have one sacroiliac joint problem, it's really on whichever side of the joint. Kind of starts just lateral to the spine, meaning kind of just outside the middle of the spine, and it tends to start kind of right over this area. So if we palpate this area in your low back, that's where the patient tends to point to, man, it really hurts kind of right in this area right here. And then it may radiate down into the butt. It may radiate down the back of the thigh. It can radiate to the side of the thigh. It can radiate into the groin. It can also radiate into the front of the thigh. Sometimes maybe even down farther in the leg. It does not tend to radiate up higher into the back. So it would tend to start in that kind of bony area that we can palpate and kind of spread down and out from there. Like the things you already mentioned, we would be expecting some type of history of maybe some of those things that you talked about that would lead us to think more of a sacroiliac joint. What else about the pain can help us think of the sacroiliac joint? So you really shouldn't have numbness and tingling. It would be less likely to be like a burning type sensation. That would be more related to like a pinched nerve, like we've talked about in other podcasts. Let's see what else. And then, yeah, go ahead, mate.
Well, I mean, just to stick along that line with like pinched nerves, the location that Dr. Bonner showed where most patients will experience some pain kind of right over that little bony prominence, we see a lot of patients where, it's kind of that dimple area in your low back that everybody points to. They might feel like it's a little swollen in that area. What you're really feeling is kind of that top of that SI joint or part of it. But even if you have like a herniated disc or disc-related issue pressing on a nerve, most of the time you feel pain in that area as well.
Yeah.
That's why it could be a little tricky just going based on location.
Right.
But some of the good clues that you mentioned, no numbness, tingling in the leg, you're probably not experiencing burning pain. Again, something that would make me think more disc rather than SI joint would be, oh, well, it hurts a lot when I'm sitting or bending over, but when I'm standing or walking, I'm okay.
Yeah.
Um, to my knowledge, there hasn't been a great description as far as like a classic type of presentation for sacroiliac joint pain, but I often think of it pain in that location and often worse with like transfers or
Yeah.
like anytime you're putting stress through that joint.
Right.
So whether you're going from a seated to standing position, when you bend forward and backwards, you get maybe 2.5 degrees of motion through that joint. But I'll ask patients a lot, well, how is it when you're going up and down steps? So different type of transfer positions, maybe a little like squatting down. So how
Yeah.
about you? Is that
Yeah,
something?
that's what I was thinking too. That's the other thing I was trying to add was definitely like if you're sitting for a while and then you go to stand up and you get kind of a pretty intense pain kind of back in that area that we're talking about, that would lead me to think to the sacroiliac joint too. Now you can also get that kind of transfer type pain when you're going to stand up if you have instability of a segment of the lumbar spine. But I would differentiate by where the pain is located. Typically, I would go if it was higher up, then I would think that was more of like one of the segments being unstable as opposed to pain from the sacroiliac joint if it was a little lower down and a little more to the outside there.
Yeah, and patients at home, if you put both your hands on the top of your hips and you kind of push in at your side and you feel that bony ledge that your palms kind of rest on, that's your iliac crest, we call that. And that's if you kind of drew an imaginary line straight across from both sides to your low back, that's kind of the L4 level. So, pain kind of at or just below that level, you might think more lumbar spine. Pain lower down or, typically below the belt line, you might be thinking more sacroiliac joint.
Yeah.
Um, the difficult thing with sacroiliac joint is unless you have, you've had trauma where you have a true shear deformity or stress where your pelvis is no longer aligned, or recent pregnancy or inflammatory like arthritis. X-rays, MRIs, CAT scans often don't do justice with regards to kind of identifying pain. So we really do rely on patient history as well as some dynamic movements and physical exam maneuvers. I always tell patients we're trying to build a case for the SI joint. So if the pain's in that area, but we put you through a whole battery of tests and doesn't reproduce that same pain, I'm less confident that it's coming from that joint. So we really want to see multiple positive findings on exam for us to feel confident that this is most likely coming from that joint.
Right.
Do you want to talk about some of those exam maneuvers
I don't
that
know
you
if we
may
need
do?
to go. I don't know if we need to go crazy so patients are like doing all these weird things to themselves, but it has to do with kind of mobilizing the hip joint and trying to mobilize parts of the pelvis to see if that creates pain. And so we're trying to stress the pelvis to see if we can irritate the joint and cause the same pain that you have. And if we can't do that, then it's a sign that maybe that's not where the pain is coming from. And there's so many tests available. There's more than a handful. And some studies have been done to show that to really increase the likelihood of kind of a positive response to an injection, you should have kind of at least 3 of 5 specific tests. That was one study that studied 5 tests, and they said you should have at least 3 of these to really expect to get a good response from an injection treatment to the sacroiliac joint. And so that's kind of what I look for is, are there multiple, just like you said. If there's one, I would be less likely. I would be more likely to go towards, what are the other things that can cause this kind of pain? And that's where I would lean towards maybe a disc herniation with nerve irritation. And maybe the pain's just not really going down the leg. Maybe it's just radiating out into the butt and the lateral thigh. Or is it pain from one of the small joints, one of the facet joints in the low back? That pain can be in a similar area too. And so sometimes I would lean more towards those in those cases. What do you think?
Yeah, I think what we can do is we'll probably put together a little handout that will be available on our website or maybe in our blog as far as kind of self-diagnosis of SI joint pain. Where we could kind of go into some detail about some maneuvers that you might be able to do at home, to try to narrow down the cause of the pain. But I would
have to
agree
lay on my desk in a funny, awkward position for you to see a video of those maneuvers right now.
None of us want that.
Nobody wants to see that. Yeah.
No, please no.
Yeah.
But I think it goes back to kind of, what is the I guess the pretest probability, right? So in certain patient populations, sacroiliac joint pain more common, others less common, right? So the more common would be the patients the different kind of conditions we talked about before. So if you have a younger patient, or if you are younger and you have pain in that area, it might go down the buttock a little bit. Sacroiliac joint pain, if there's no other trauma or anything, it's probably lower down on my list, right? Just like you said, we're ruling out disc issues and other things. If you're 50 or 60, had a couple fusions in your low back, and the sacroiliac joint is the only joint in the lumbar spine that's not fused, well, it's more likely than not, or I'm ruling that out first. So each patient and each patient scenario has to be taken into consideration for that. But I just from an imaging standpoint, I might do just X-rays. Really, I'm never really ordering advanced imaging of the sacroiliac joint prior to initiating treatment. How about you?
Yeah, unless there's trauma.
Sure.
Sometimes I've seen you can see kind of a fracture kind of through the joint or in the sacrum there. And so if there was trauma, I'd be more likely to order some piece of imaging like an MRI or a CAT scan. But otherwise, an X-ray usually suffices. But with trauma, definitely beware that an X-ray may not show the whole story. If you're looking at the pelvis and the sacrum there, there's a lot of kind of blurry lines there in the sacrum if you're looking at an X-ray, and you can miss a fine fracture. And you get a CAT scan and it can be very obvious, but you look back at the X-ray and you say, I really don't see it there. So if there's trauma, that would be the time that I would order some advanced imaging.
I guess the one thing we should also mention, from an osteopathic perspective, right? We always talk about physical therapy and chiropractor, which we'll briefly talk about. But from an osteopathic perspective, even on physical examination, there are some findings that you can pick up that might suggest pain is coming from that SI joint. You might often hear, or patients might have been told, "Oh, I'm out of alignment," or "My pelvis is out of alignment." Right. So, because those ligaments and joints do have some motion to them, one side, even though they're connected in the center, one side can rotate maybe a little forward, one side can rotate backwards, and you can put some shear stress through there. So that's something else on examination and something in that blog post that we can touch on more. I guess myself, I'll at least tell you kind of my approach to SI joint pain. If we're starting out from a conservative standpoint, once we have a highly educated opinion or hypothesis that the pain is coming from the joint, I will discuss with my patients. I'll either start with some physical therapy or kind of some manual therapy, whether it be a chiropractor or osteopathic physician who practices OMT. Um, I don't necessarily have a preference. I like the manual therapy for this area, but you can get the same type of improvements through stabilizing the structures and muscles around the joint as well. So almost a more indirect way to stabilize the joint. Do you have a preference?
Just in my patient population, I'm generally dealing more with geriatrics, and so um, I would say that it's just more probably like variety degenerative arthritis there. And so I tend to go more for stability, but also a lot of these people aren't doing like good exercise programs and aren't willing to do them. So um, I just tend to stay away from, like aggressive manipulation of anything, I would say, like manual in terms of like massage and kind of some muscle energy techniques and things, fine. But I stay away from kind of aggressive manipulation with them. And then I tend to help the stability, I tend to go more towards like getting like a sacroiliac belt early on to see if that helps them. Do you use those at all?
Not really.
Yeah.
I find that unless they're a tiny patient, and
Yeah.
it's hard to wear them, it's hard to get them low enough, tight enough.
Yeah.
Um,
I've had some
I'm
people
not,
come in though and tell me, they come in with a belt really tight and really low around their waist. They're like,
uh,
this is the only way I feel better. And I'm like, all right, well, you figured it out already. They may,
yeah.
they make something for this, but yeah, I think it's just something that I try. It's hit or miss whether or not it works and whether or not they can tolerate it. And like the to be the right body habitus. If you're really large, it's not going to stay in place and not going to have an effect. But there's definitely some patients where it's a good kind of minimal intervention that helps them.
Yeah, I mean, it couldn't hurt to try. Um,
I think it
I
also
think,
helps with the diagnosis too. Because if it works, it's pretty clear that it's kind of a sacroiliac dysfunction or instability. Because if that immediately relieves the pain, it really shouldn't be something else that's causing. I mean, it could be, but it shouldn't be something else higher up in the spine getting benefit from that. So,
yeah, and I was going to say it can kind of tailor your treatment protocol too, because
right,
then you're looking more stabilizing type treatment
yeah,
or protocol. Um, let's get into interventions. So, non-surgical interventions, specifically injections or procedures around that SI joint. Uh, I think it's safe to say majority of physicians or interventional spine docs, once patients who have been diagnosed with SI joint pain, undergone appropriate conservative care, and continue to have pain, I would say the next step would be a sacroiliac joint injection. Um, uh, would you agree with that?
yeah. That's exactly what I would do.
Okay. Do you want to pull up that model? Maybe you could show where that joint injection would be. So the
Yeah.
sacroiliac joint, it is large, but it doesn't hold that much volume, maybe 2 cc's, maybe 2.5. But where there's cartilage, just like you have cartilage in your hip or knee, is on the bottom part of that joint where Dr. Bonner's finger is there. So we typically target that area with a needle to put the cortisone. It's usually a mixture of cortisone and lidocaine into the joint. It will spread around throughout the joint, but typically we target that in what we call that inferior 1/3 of the joint. Usually done under X-ray. It can be done under ultrasound. Um, either way, you want somebody that's skilled in doing these. I remember reading a study a while back. If you do a blind SI joint injection based on palpation, which I think was much more common years ago, you have like a 12% chance of getting in the joint, right?
Right.
So if someone is doing an injection based on palpation where they're touching you and you say, oh, it hurts here, and they give you an injection and they tell you they injected your sacroiliac joint, that's not accurate, right? They did what we call a trigger point injection. They just put some steroid and Novocaine mixture likely in the muscle and maybe, if you're lucky, over the back part of the ligaments of that joint. But, so you did not have a sacroiliac joint injection unless it's confirmed with image guidance.
Yeah.
Anything to add to that point?
I mean, I guess we could just make a comment about, even though sometimes we may inject into this joint, there's a capsule that surrounds it, but the capsule can be missing pieces. And so some of that injection may actually leak out of the joint and go to other structures. And so it may leak into those ligaments that Dr. Connor was talking about previously. It could leak out into some of the nerve roots that come out anteriorly. And, we would hope not, but so that we could be more specific, but sometimes it may leak out. And so it may give us kind of a false response to the injection. Maybe we inject into the joint and, one reason to use lidocaine when we do these injections is to see the response a patient has immediately after the injection. So if you feel great right after the injection, we think, okay, well, it was probably the sacroiliac joint that was the problem, but the medication also could have leaked back onto these ligaments that are posteriorly. It could have leaked out anteriorly, and it could have numbed up some other structure that was what actually made you feel better. And so, so that's just one caveat when we're doing that procedure, that we need to be aware that maybe it's not so specific some of the time. Yeah, I don't know. What do you think about that?
Yeah, I mean, it is, I forget the exact numbers, but the capsule can be leaky, and just like you said, it could leak out different places. It could be perfectly placed, and some of it leaks out just because, and you might not have that effective of an injection. But again, that's where image guidance is important, and primarily X-ray guidance or fluoroscopy for that purpose. And contrast would have to be used as well.
Yeah, are you always using contrast?
I am. I mean, maybe once a month or once every couple months, there might be a specific case where I might not use some contrast for a specific injection on a patient, usually due to kidney function or severe anaphylactic reaction, and different things like that. But when I review a lot of other physicians' imaging, whether patients bring it to me or for other purposes, I'm surprised by how many docs don't use contrast for a lot of their injections.
Right.
And just like we've talked in previous podcasts, that should be a red flag. If you're, as a patient, if a physician routinely does not use contrast for their injections, that should be a red flag. That, how do you know you're even in the right place?
Yeah. And even if the needle is in the perfect place, the medication can still flow to the wrong place. And so just like we were saying, even if you're perfectly in that inferior recess of the sacroiliac joint, or that inferior 1/3, the medication can still flow backwards out of the joint. And so you may have to readjust the needle to get appropriate flow. And it may just be sometimes you might just turn the needle 180 degrees and the medication will flow differently. But that's the important part of using the contrast, is really making sure, even if the needle is in the perfect spot, make sure that medication flows perfectly as well.
Yeah, these injections are either super easy or very challenging.
Right.
There's no real in between.
Right.
These just because of the anatomy and the way joints are angled, and then throw on top of that arthritis, they can be challenging sometimes to get into.
Right. Definitely. I like to try to, if there is advanced imaging, I really like to try to look at that to see what the angle of the joint's going to be, because the joint can really be, it can be lined up kind of this way at the top and that way at the bottom, or the other way around. And so it can be difficult to get good entry into that joint, and sometimes some of the imaging can be helpful.
Do you have like and this, I'm more just curious, do you have a standard kind of setup for your SI joint injections with regards to your X-ray? Like
Uh,
how tilt to the head, ipsilateral or contralateral oblique?
I tend to tilt up to square off the L5S1 level, and then um, I just go straight on, and then I go one way. I tend to go lateral, so ipsilateral oblique first,
Yeah,
and see if the two edges of the joint seem to come together, and then if they don't, I'll go back the other way. But I tend to go
gotcha.
ipsilateral oblique first.
Yeah,
That's a little more in the weeds for the patients there, but just some technicalities of the injections. But
yeah,
it's just a sign of it's a difficult injection to do, even though it may seem easy sometimes.
yeah. I was just curious.
Yeah.
Um, so then at least in kind of my day-to-day practice, if a patient, we do an SI joint injection, uh, they do well, but it doesn't last, or meaning it might have worked for a couple of weeks or maybe a month or two, or maybe during the anesthetic part. So when that Novocaine was in there, it felt good, but again, a day later, they found no benefit. Typically, that's when we'll look at the ligaments on the backside of the joint. Now, you talk to different doctors, and maybe that's not the best way to approach it because the the joint and the ligaments are two totally separate structures. Um, and the nerves that go to the ligaments in the backside of the joint, um, you know, there could be two totally separate kind of issues in general, but that's kind of how I approach it. So I'll then look at what we call the sacrolateral branches to see if we could perform something called radiofrequency there to kind of temporarily block the pain signals going from those little nerves to the brain. Is that kind of I guess is that what you would consider in patients who the SI joint injection doesn't provide much relief, or will you repeat the injection?
I will not repeat the injection if a patient doesn't have more than at least, you know, a month of relief. Or if a patient may have like 50% relief that persists, I may repeat an injection to see if we can get relief on top of that. But if the relief doesn't persist, then I would tend to do what you're talking about, is doing the lateral branch blocks. And we've talked a bit about a similar concept before in the facet joint lecture, but basically we're talking about blocking the nerves that carry the signals from the joint so that you can't feel the pain anymore. And then if you can successfully block those nerves, there's a radio frequency procedure used, like you mentioned, that we can kind of destroy those small nerves and hopefully take away the signal of pain and make the patient feel better for a longer period of time than from just lidocaine, which really only lasts maybe an hour or two, depending on the patient. So that's also my next approach for sure.
Yeah, and it's tough in this type of format to really go into details as far as how the radio frequency ablation in the sacroiliac joint area would work. But there have been recent studies out there that have been able to identify the best technique for an SI joint radio frequency ablation.
All
So
right.
I think it's worthwhile at least mentioning that because there are a lot of different variations of how this procedure is being performed. And a lot of the ways that are done really aren't capturing the nerves or the treatment area as desired. So patients may have undergone what they were told was a SI joint ablation or sacrolateral branch radiofrequency ablation, but And in all honesty, they probably, it was as good as sham.
Yeah, and we can show here a little bit kind of where those nerves travel. Um, they tend to travel, the lateral branches tend to travel from these little holes here, then out to the side to where the joint is. Um, and people have identified those nerves in cadavers to see exactly where they travel or where they tend to travel. And so the idea is to kind of burn where those nerves travel along this line so that the nerves can't get to the joint and the signal can't get back up to your brain and you can't feel the pain. And like Dr. Connor said, I would say that this is a sort of a more recent utilization of the radiofrequency procedure, and the best practices are still kind of being identified. And so everyone should be kind of staying up to date with what that practice is and using whatever technique kind of is best known to destroy those nerves.
Yeah, I mean, I guess if we're always trying to give patients and our listeners some tips, if you're talking to your physician and they are talking about doing this procedure, you could always ask them, well, what technique do you use? If they mention, oh, there's a special wand that it's a one needle type wand that is done, that's actually not that good. So you want to kind of tell them, well, I've heard that's not the best way to treat that. And or if they say, oh, we use a single needle, again, not that good. The two best ways, I guess, would be like a bipolar approach, or there's what's called a Palisades approach based on this article that was out. But that's kind of how it's described. And when I talk with other professionals, and I use the Palisades technique for radiofrequency ablation. So if you want to sound really smart and you're talking with your physician or the interventionalist who's going to perform this, ask them, are you using the Palisades technique? If they're not, I would almost caution you not to go forward with the treatment at that location, because they're obviously not up to date on the research, and you might have a subpar treatment. So
yeah. What about I've heard some people like to use what we've discussed before is prolotherapy to maybe stabilize the joint. Do you do any of that, or know people who do that?
I don't do too much of it. Done it a couple times. I would say I think there is a role.
You want to
Some of
just
those
describe that
patients.
a little for patients?
Yeah, well, prolotherapy's been around for, oh God, a long, long time. Probably
Yeah, I mean,
much longer.
my dad says my grandfather used to do it.
Yeah,
So
and
that was a long time ago.
yeah. So you're injecting kind of an irritating agent to induce an inflammatory response, to help with the body's own natural healing. That is kind of most simplistic terms. Now, people who are very strict and staunch supporters of prolotherapy, I mean, for different structures in and around the body, there are certain protocols for, oh, you should do this ligament or this tendon and vice versa. But for what we're talking about, prolotherapy to the ligaments on the backside of the sacroiliac joint to help with stability and pain. Now, I've seen it utilized in some younger patients who might have laxity in their ligaments, whether from post pregnancy. One other group of patients we didn't really talk about, but like hypermobility syndromes, whether like a Ehlers-Danlos, or there's some benign hypermobility syndromes that may run in families where just your ligaments are kind of really laxed and loose, and you can hyperextend joints and all that.
Right.
In those patients, I've seen it and I've used it in those situations. I haven't for some of the more kind of maybe degenerative wear and tear post fusion type patients.
Mm-hmm.
The one tough thing with the Prolo is, well, it's not covered by insurance usually, so you are paying out of pocket, but you usually have to do repeated sessions. And I've always kind of piggyback that on top of like a formal PT program with stabilizing type exercises.
Right.
How about you?
Yeah, I haven't done it ever. I've just heard from some people who use it, and it makes sense in the fact that you could hopefully stabilize the joint a little bit better. But I don't know. There's probably not a great study to say yes or no about it. Um, and then some of the other things that I was thinking about was like, we've talked about regenerative medicine a little bit. Like we said earlier, the joint it does have cartilage, hyaline cartilage, just like a lot of the other joints that you may get treated with something like PRP, or which is platelet rich plasma, or stem cells with. And theoretically you could use it the same way in the sacroiliac joint. Again, it should probably be an image guided injection right into the joint so that we know exactly where it's going. Is there any study or any great evidence out there to show that that works really well? None that I'm aware of, but that's probably something that some practitioners are doing and some patients are paying out of pocket for, and it's probably generally pretty safe. But that we don't need to get all the way into the details of that. But
No, I would just say I would agree. It's, I think the use of PRP and stem cell have been shown to be safe for various musculoskeletal issues. But, in my opinion, we have pretty good treatments, with regards to either sacroiliac joint injection or the radiofrequency ablation, that in most insurance plans do cover. There's a couple out there that might not cover the SIRF, but I tell patients I would, we know what a typical response should be from those treatments. If we're moving forward with an SI joint RF, we're doing the test blocks beforehand, so we feel pretty confident that this is going to help. I typically would recommend going that conventional way prior to trying some more of the experimental
yeah,
options.
yeah,
Um, again, this could be in the blog, but always making sure, and anybody with SI joint pain, quadriceps, hamstrings are nice and it could be flexible to a point, but you want to make sure one is not extremely tight compared to the other. That's causing some abnormal torque on the pelvis and putting stress through the joint. Similarly, some patients, they might have SI joint pain, but they have a really bad hip or a knee. So we'll treat the hip or the knee pain, and the back pain gets better. So and correct me if I'm wrong or if you have a different approach, but my general rule of thumb is if you have a back issue and a peripheral joint issue, whether it be a hip or a knee, typically I'll treat the peripheral joint issue first, and sometimes the back issue kind of calms down on its own.
yeah. I mean, I think you get that story a lot where people come in and they're limping pretty hard on one hip or knee, and they say, "Yeah, that's been hurting for like 6 months, but now my back started to hurt." And I'll agree. I say, let's go for what seemed to lead up to all this. So yeah, and definitely once you start walking normal again, a lot of times it starts to feel better. So
Yeah, and I'll see like post total hip replacements or knees. Sometimes it has the other effect, right? I mean, it's difficult sometimes to match up leg lengths exactly right, or if they correct a leg length discrepancy, and now you're walking differently than you have been, you can put a lot of stress through that SI joint. So even in the post-operative setting, sometimes we'll treat SI joint issues.
yeah, it makes sense. Definitely.
Um, okay, I want to ask you your opinion on sacroiliac joint fusions.
I was going to ask you your opinion on
Well, don't worry, I'll give you
that.
mine too.
Yeah. Um, I mean, I've never done one. I've never sent a patient for one. I I'm not aware of any good evidence to support the use of the procedure, but I know that it's widely publicized and it's widely practiced. But I honestly I've never done one, and I've never sent a patient for one because I've never had a patient who I thought would really benefit from one. And I've seen patients who have had them, and I think generally the response was that it didn't help. But then again, if they had one and it helped, they probably weren't coming in to see another spine doctor. So, I'm sure there's some patients who benefit. I don't know what that percentage is, but and you would think that the theory behind it makes sense, to stabilize maybe mildly unstable joint, and then it won't be painful anymore. But I don't know, that I don't think that has been shown to be the case necessarily. So
Yeah. And can you show on your model kind of what that would, your trusty model there? So with
so you
the, go ahead.
no, you just like, I think there's some different ways of doing it, but some of them basically kind of put like a screw type thing right through the joint to just lock the joint in place.
Mhm.
2 or 3 screws, and right through, and then some of them maybe have like a bone graft in there so that it'll grow some bone into where that joint is and really kind of fuse the joint. Um, and that could lead to all kinds of different problems after that too. So, yeah.
Yeah. I mean, I guess we should always say as technology gets better with any type of fusion, potential for good outcomes, I'm sure will get better as well. My personal opinion, if I had a family member who was dealing with this issue and was offered a sacroiliac joint fusion, either by an interventional pain physician like ourselves or a spine surgeon, I would tell them not to do it. That's my opinion. Yeah, we all have a biased degree based on the patients that we see. We're obviously either treating people leading up to it or people who still have pain afterwards. But my general rule of thumb is attempting to immobilize that joint or other joints in the spine. I think long-term outcomes have not been that positive in general, and then it could cause more harm than good. Um, I will tell you, I've done quite a few SI joint RFs, or RFs over the sacrolateral branches and the posterior ligaments in patients who have had SI joint fusions. So,
Yeah.
I that's my answer. I'll stay as politically correct as I can.
Well, I mean, sometimes fusing a joint doesn't take away what can cause pain there. And, just because you fuse that joint, it doesn't mean you take away all the stress in the joint. I mean, there's nothing that's ever shown that. If you put a few screws through it, you're not taking away all the stress if someone stands on one leg or gets up out of a chair. So you can imagine that. I mean, look, if you get your hip fully replaced, they cut out the part of the pelvis where the hip goes into, and they cut out the top of the hip. So you have a whole new joint. You don't have any of the remaining cartilage that was all damaged and generating a lot of pain. But in the sacroiliac joint, that's not what's being done when you have the fusion. And so, maybe someday there'll be like a fantastic sacroiliac joint replacement where they put 2 new components in and it glides really nicely. But right now that's not the case. And maybe the procedure's being a little overutilized because, look, it's easy to do. It can be done by a lot of practitioners. It's not it's not a really in-depth surgical procedure. A lot of people who aren't even surgeons are doing it. And I'd be lying if I said that it didn't. I'd be lying if I said that it didn't reimburse a lot. I'm sure it reimburses plenty. So, it's just another motivation to do it. So, but like you said, we got to do what's best for the patient.
Yep. Yeah, I would agree. There's a lot of factors and variables that go into medical decision making in our current healthcare climate. So, but it comes down to doing best for the patient. And my general rule of thumb, if you're ever offered a surgery on your low back, right, whether a decompression type where they just remove bone and other maybe disc, or they put hardware, or they fuse something, I always get a second opinion, right?
Yeah.
Always get an opinion with two different surgeons. If their opinions are wildly different, that should throw up some red flags. If they're pretty similar and you have a trusted, maybe non-operative musculoskeletal physician who's kind of helping to guide your care and direct it, that's where I think we have a good role with regards to that. Even though we don't do the surgery, we have a good understanding of when it would be indicated, what would be appropriate. So when I send patients to see a surgeon, if their recommendations come back and I'm kind of scratching my head, well, that kind of throws up some red flags as well. And then we're getting a second opinion, and then we really have to talk it through with the patient to make sure they understand what the potential consequences are. Anything else you think we missed on this riveting talk about sacroiliac joint pain?
No, I think that's great. If you have pain in their low back on one side and you have a history of any of those things we talked about, it could be your problem. And we're happy to talk to people about that if you think so. So, I think that's good.
Yeah, like Dr. Bonner said, you could check us out on our website. You could check the video for today's podcast on YouTube. We're even getting a little Instagram page going, and we're getting more stuff out there. So hopefully some more education material for our patients. That's what it's all about. So if you have any questions, please feel free to contact us.
All right. Have a great night.
You too, buddy.